infections of the central nervous system. Now, before starting, what are the parts of the central nervous system? So, the parts of the central nervous system would include the brain itself and the spinal cord and its appendages. The appendages include the coverings of the brain and spinal cord, also called as the meninges. What are the meninges present? If you can see this picture, so this is a representative diagram of the brain, the spinal cord, and the appendages. So any infective pathology that goes on these structures will called as the constitute the CNS infections. So basically, we can classify them into 4 types of infections. So broadly, we can classify them into 4 types of infections. The first would include the inflammation of the appendages, that is the meninges. So any inflammation of the meninges will be called as meningitis. The second part would be the pathology that goes on within the cerebral matter itself, or the encephalon. That can be called as encephalitis, and sometimes some of the other diseases also called as encephalopathy. Now, encephalopathy means the disorders of the encephalon. Encephalitis is one of the encephalopathies. Coming back to the next type of lesion, we can also called as SOL, or space occupying lesion. Now, keep in mind that our cranial cavity is a rigid box. So any kind of lesion in this will lead to a pressure effect. So any space occupying lesion will also have a mechanical effect on it. May have an infective implication or may not have an implication. So those are called as space occupying lesions. And finally, among the other infections, we can classify them as, first is called as shunt infection. What is shunt? Any idea? No. So basically, there is a pathology that is called as hydrocephalus. Now, what happens in hydrocephalus is the cerebrospinal fluid, absorption of the cerebrospinal fluid may be altered, and this leads to excessive accumulation of the cerebrospinal fluid in the meningeal space, resulting in increased cerebrospinal pressure. To alleviate the pressure effects, we can put what is called as a shunt. There are many types of shunt. What the shunt does is it redirects the cerebrospinal fluid from the meningeal space into other body spaces, like very commonly used is a peritoneal cavity. Now, whenever we are putting a shunt, that's a foreign body. So there is more propensity of getting infected. When this kind of infections happen, we call it as shunt infections. Understood? The next would be myelitis. What is myelitis? Conduction of the neurons and also maintaining the viability of the neurons. So many a times it is seen that the nerve itself is not affected, but the myelin sheath may be affected, and those are called as the myelitis. Very commonly, I think you would have heard about something called as transverse myelitis. Have you heard? Okay, fine. And last is what is called as toxin-mediated effect. Now, toxin-mediated effect may be a localized or may be systemic. Can you name any systemic infection which leads to CNS manifestations because of the toxins? Very good. I said neuronal effect. Now, what kind of neuronal effect do we see in case of tetanus? Spasm of the muscles. Anything else? Any poison? No. Tetanospasmin is part of the pathology of the tetanus. Any other similar to tetanus? A poisoning, very commonly, strychnine poisoning. Anything else? There is a spider, black widow spider. Okay. In contrast, we can have what is called as botulinum toxin. Clostridium botulinum. It causes botulism. So these are all toxin mediated. That means the toxin is produced at a distant part of the body. It is absorbed systematically, and then we have the neuronal effects. So this is how we can easily classify the 4 infective process that goes on within the CNS. So those would be meningitis, encephalitis or encephalopathy, then specific occupying lesions, and finally we have other infections. Now let us look at them one by one. First we will consider meningitis. Now meningitis, as I have already said, is the inflammation of meninges. Now it can be acute, it can be chronic. Acute means, what do you mean by acute presentation? Huh? Initially, every disease process has an initial point. Now, what do you mean by acute? Most important, it's a sudden onset. We call it as acute. There are many diseases. We have very different classification. What do we call it as acute or chronic? But the idea is, when the disease onset is sudden, we call it as acute, and when it is more insidious, we call it as chronic. So, like most of the diseases, we can classify meningitis into either chronic meningitis or into acute meningitis. Again, we have many etiology of meningitis. Based on that, we can classify them into either bacterial meningitis or a viral meningitis or a fungal meningitis or parasitic meningitis. And sometimes even non-infective causes can also cause meningitis, like syndrome, like drug-induced or a toxin-mediated. Now coming to the etiology, look at this chart. First, acute meningitis can be differentiated into 2 important parts. One is called acute bacterial meningitis, another will be acute viral meningitis. Okay. The common causes of acute bacterial meningitis would include, what are the common causes? চারটা দেখার দরকার নেই, common organism কি পড়েছে? Okay. Look at the etiological agent. First is pneumococcus, streptococcus pneumoniae, meningococcus, Neisseria meningitis, then Haemophilus influenzae. Now all these 3 pathogens have a specific property. They are all capsulated. Because they are capsulated, the capsule has a virulence factor and it predisposes for meningeal infection. The next common would be Listeria and Streptococcus agalacti. Streptococcus agalacti is found in, commonly seen in, where? Less than? Okay. Now where it is found commonly? If you understand these things, then when you try to recall the pathogens causing acute meningitis, won't be much difficult. Next, gram-negative bacilli like E. coli, Klebsiella. Now another method of classifying, I'll go into much detail a little bit later on, based on the age of presentation of the patient. Okay, so we can classify them as infant, that is 0 to 1 year. The meningitis in infants, meningitis in childhood, meningitis in adulthood, and meningitis in elderly. Why we need to classify them? Because the etiological agents are different. Furthermore, each and every specific group are susceptible in different ways. Elderly people will have more decreased level of immunity, hence some of the pathogens which will not commonly cause infection in adult may cause infection in elderly. Next part is, again we differentiate between bacterial and viral meningitis. The basic purpose of differentiating between bacterial and viral meningitis is how it was called earlier. Earlier, most of the viral meningitis was called as aseptic meningitis. Okay, colloquially we can say aseptic meningitis is also viral meningitis. Now what do you understand by the word aseptic? Aseptic means something that is not septic. So what do you mean by septic or sepsis? Septicemia means it's a process. Now, what do you mean by sepsis? That means the organism is present and it is causing the pathology. So, what used to happen earlier was when meningitis patients, people used to draw the cerebrospinal fluid and look the fluid under the microscope. So, if the etiology is a bacteria, it can be easily seen on gram stain. But some of the cases, the bacteria was not seen, yet the patient presented with signs of meningitis. Hence, it was called as aseptic. That means no pathogen present. Later on, as science developed more and more, we came to understand that these were caused not by bacteria but caused by viruses. Hence, was not seen by routine microscopy. But we can see the viruses under electron microscopy or by molecular methods. Hence, it was earlier called as aseptic meningitis, but nowadays we'll be calling them as acute meningitis. Okay. So, common viruses causing meningitis would include enteroviruses, herpes viruses, and others rare causing viruses. Coming to chronic meningitis. Now, chronic meningitis means a disease process which is insidious in onset. That means the presentation is a prolonged period of presentation. So, these will be generally caused by organisms which are virulent, but they constantly fight against the human body. That means human body is able to resist to some degree, or the organisms are slow growing in nature. The two very common types of chronic meningitis commonly seen is caused by Mycobacterium tuberculosis, causing tuberculous meningitis, or especially in immune compromised we can find fungal meningitis. The common fungal meningitis or meningoencephalitis caused in immune compromised patient would be caused by a fungus called as Cryptococcus, commonly neoformans. Now, coming to encephalitis or encephalopathy, as I have already said, encephalitis means there is a direct inflammation. This can be seen with agents like most commonly viruses, which include herpes viruses, both herpes simplex, cytomegaloviruses. These can cause encephalitis. Furthermore, we can have other viruses like rabies and organisms like toxoplasma. What is toxoplasma? পড়ানো হয়েছে তো? What is toxoplasma? Toxoplasma gondii. So it's a parasite. So some of the parasites can also cause encephalitis. It is called as toxoplasma encephalitis. Furthermore, we can have what is called as encephalopathies. Some of the viruses will cause pathological process in the brain itself, but the presentation is very slow. These are also called as slow viral diseases, and some of the parasites like malaria. Not all malaria, but falciparum malaria may sometimes complicate to form what we call as cerebral malaria. So this is not encephalitis. We call it as encephalopathy. Now, coming to space occupying lesions, I have already said the predominant pathology is caused by direct occupation of the space in the cranium leading to pressure effect. Now, this can be caused either by focal CNS lesions. These would include brain abscess. Now, why brain abscess is so important? Many a times, for example, like in tuberculosis, sometimes meningitis is not seen. The organism may gain access into the cerebral cortex and slowly and steadily will cause an inflammation. Now, like the same kind of pathology that is seen in the lungs, it will cause granulomatous lesion. Slowly the lesion will go on bigger and bigger and may lead to direct effect or indirect effect. Similarly, we can find even in case of Cryptococcus, it can cause cryptocoma, or we can find cystic parasitic diseases like neurocysticercosis. I think you have read about neurocysticercosis. where the cysticercus larva enters into the cerebral cortex. It itself does not cause much pathology, but as the larva grows, it may cause direct pressure effect, and sometimes the larva may die and its internal fluid come out, which may cause various CNS effects. That those may include seizure activities. And finally, I've already told you about the shunt infections, myelitis, and toxin-mediated disease. Now, all things said, this central nervous system is a anatomically very privileged site. When I say anatomically privileged site, what do I mean? Any idea? Now, is there any direct blood supply from outside? No. It is a secluded site. That is the reason why cerebrospinal fluid is sterile. There are no organisms. Okay. So normally it is not possible for a pathogen to reach into this space. How does it reaches them? The first method would be through hematogenesis. How? Where is cerebrospinal fluid produced? Which plexus? There is a plexus called choroid plexus. So how is CSF produced? What happens in this plexus? The fluid actually comes from the blood vessels through the plexus into the cerebrospinal space, right? If any organism can cross through this barrier, can gain direct access into the cerebrospinal space, thus causing it will reproduce within this space, causing inflammation of the meninges and causing meningitis. Many organisms can cause meningitis through this route. Hence, this is the most common route by which meningitis is caused. It may be acute, may be chronic. For example, in tuberculosis, the primary location of infection is lungs, or cryptococcus. The primary location is lungs. From there, the organism moves into the blood circulation. From there, from heterogeneous route, it will enter into the cerebrospinal fluid. So that is the first route of acquiring the organism. The second route would be from the local tissues. What are the local tissues which may harbor the organism? What are the spaces in the head and neck? Right, there are the sinus cavities, also called as the paranasal sinuses. Then there is another big cavity over here. What is this called? Mastoid process. And internal ear. So any infection, chronic infections, chronic sinusitis or chronic otitis media, the organism lies over there and it can cause localized infection which may spread into the central nervous system. Another route is through direct neural invasion. There is one particular nerve which is directly connected. Can you name? That nerve is responsible for one of the 5 senses. Olfactory nerve. That is, the nerve ending is present in the olfactory bulb. So many organisms, especially many bacteria, they will colonize the nasopharynx. And from there, through the olfactory bulb, it can cause direct infection of the CNS. That is the reason why I told you some of the capsulated bacteria can cause meningitis very common. So what are the capsulated organisms? Neisseria meningitidis, then Haemophilus influenzae and Streptococcus pneumoniae or pneumococcus. Okay, so these are the very 3 common organisms. Now, how does a person acquire in the nasopharynx or the oropharynx? coming in contact with another person. So whenever a patient sneezes, coughs, the organism is there, and then another person smells, local colonization occurs and the infection occurs. Understood? Last but not the least is what is called as any abnormalities in the CNS, like say a fracture. There is a trauma, there is a fracture. That means there is an abnormal pathway through which an organism can gain access. In the direct neural spread, another method, I think you have read about herpes infection, varicella infections. So what do these viruses lay dormant? At the ganglions. And then there is a neural spread. Sometimes away from the central nervous system, sometimes towards the central nervous system. For example, herpes virus, they can spread the infection through the neural roots. Okay. So what are the roots of infection? One would be through a hematogenous route. The second would be direct spread can occur by no. First is the local infections. It may be a sinusitis, mastoiditis, or otitis media. Next would be if there is an abnormal path like a fracture or a wound or a surgery, or it could be a direct neural spread. Okay. I think you already know the definition of meningitis. Fungal meningitis is generally said more than 4 weeks, but anything more than 1 week we consider to be as either subacute or chronic. Clear-cut demarcation is sometimes also not possible, but main is the etiology that we need to know. Now coming to the chronic meningitis, these are the etiological agents, common bacteria which may cause chronic meningitis. Either I have already said it is the localized infection in the surrounding tissues, chronic sinusitis, chronic mastoiditis, or sometimes acute meningitis may not be properly treated. That is suboptimal therapy given. So what will happen? The bacteria will die, some will remain, they will replicate again, and the process will be slow. So that could be a possibility. Localized infection, then Mycobacterium tuberculosis, Borrelia burgdorferi causing Lyme disease, or Treponema pallidum, which causes syphilis. And here we are considering as neurosyphilis. So these are the common causes of chronic meningitis. Among the viruses, we can have viruses like mumps, eco, herpes virus, HIV, and LCM, that is lymphocytic choriomeningitis viruses. Some of the parasites, commonly toxoplasma or free living amoeba, causing chronic meningitis. Can you name free living amoeba? Acanthamoeba species. Okay, it causes meningoencephalitis, and some of the other organisms can also cause. Among the fungal agents, I think I have already told you, Cryptococcus is very commonly seen, other than Candida, and in India we can find Histoplasma and to a lesser extent Aspergillus. Other funguses like Coccidiomycosis or Paracoccidiomycosis are infections are generally not seen. If you can remember the first two, then that is fine. Okay. Now, today's discussion will predominantly be on how to approach to a case of meningitis. How can we, what would be the signs and symptoms of meningitis? Okay. The first we need to understand what are the presentation of meningitis. Now whenever we say there is inflammation of the meninges, what would be the first symptoms? Inflammation means ইনফ্লামেশন হলে বডির যে কোনো জায়গায় ইনফ্লামেশন হলে ফার্স্ট সিমটম কি হবে? ফিভার। দেন what will be the local effect? Pain. So if there is pain in the central nervous system, presentation is headache. And then there will be, আরে বাবা ব্রেনের মধ্যে যদি নার্ভ থাকে, নার্ভ ইনফ্লামেশন হলে কি হবে? That is seen what is called as signs of meningismus or nuchal rigidity. Nuchal rigidity মানে কি? পড়ানো হয়েছে ক্লিনিক্সে? হয়নি? নিউকাম মানে হচ্ছে ঘাড়। তাহলে যদি ব্রেন স্টেমে ইনফ্লামেশন থাকে মেনিনজেসে, তাহলে কি হবে? ইনক্রিজ cerebrospinal fluid, হেড ফরওয়ার্ড বেন্ডিং হবে না। The head will not bend forward. This is called as nuchal rigidity. And obviously the patient will be lethargic, and if the inflammation is severe, may be drowsy, may be comatose. Now the signs of meningism, very common two signs, is called as either Kernig signs or Brudzinski's sign. What is Kernig sign? Kernig sign is, if you can see, the child is laid in a supine position. Then the hip is flexed and the knee is extended. When this happens, what will happen? The spinal column will be extended. There will be irritation, and so the nerves will be irritated. The knee will not extend. So when you are trying to extend the knee, you will feel a resistance. If you feel the resistance, it is called as Kernig signs positive. Similarly, if we now in the supine position, we flex both the knees and the hips, and then we try to flex the neck of the patient. If we find resistance, we call it as Brudzinski sign positive. So these are the signs of meningitis. Okay. So clinically what we'll see, first the patient will present with fever, headache, and headache may be associated with nausea, vomiting, this kind of manifestation. Severely infected patient may also present in a delirious or comatose state. On examination we can find these neural symptoms. The next important step would be to get a what? Now when we find that signs of meningism is present, that means our provisional diagnosis is of meningitis. Okay. Now based on the presentation, we have either acute meningitis or chronic meningitis. If the patient present with a history of say 0 to 3 days or 0 to 5 days, we will consider it to be as acute meningitis. So next step would be, we need to look into the cerebrospinal fluid to isolate the organism. That is to confirm the diagnosis. How can we take the cerebrospinal fluid? There are many processes. The most common process is by doing a lumbar puncture. Now, do you know how to take a lumbar puncture? Why lumbar puncture is done? I can take the cerebrospinal fluid from any part of the central nervous system, right? Meninges are present everywhere. Then why this particular area is selected? See, these are thin layers over the neural ends, either spinal column or the cerebrum itself, and there is a very thin layer of fluid. It is very difficult to take the fluid without injuring the neural structure. So the very easier method would be to take the lumbar puncture from this region. Why? Because over here the spinal column ends at L3, L4, and the meningeal cavity extend up to L5. This is the reason why lumbar puncture is done at the side of L4, L5 in adults. Okay. The patient is presented, put in a left lateral position. The right side of the knees and hip is flexed, then the space within the L4, L5 vertebrae is palpated and the needle is pushed to get the cerebrospinal fluid. After obtaining the cerebrospinal fluid, what we need to do? The first important step is whether it's bacterial or viral. That is the most important part, because if it is a bacterial, we need to give antibacterial drugs. If it is a viral, we need to give antiviral drugs. Now please remember, meningitis is a medical emergency. Every minute you waste is very, very dangerous for the patient. Okay, you may lose the patient within about 3 to 4 hours itself. Now the lumbar puncture is very essential to obtain the CSF and to study the CSF immediately. That is fine, but you must be aware of the risk factor for lumbar puncture. The most important risk factor is what is called as cerebral herniation, convolutions. Now, because of the inflammation, the cerebrospinal fluid pressure would be very high. Now, if you do a lumbar puncture, there will be a sudden release of the pressure, and there might be herniation of the brainstem. Now, what does the brainstem control? It controls all the vital functions, including breathing. So, any kind of herniation may lead to disastrous consequences. So, it is always prudent enough to understand whether there are any signs of increased pressure is there or not. Increased intracerebral pressure is there or not. If you feel that there is increased intracerebral pressure, you must ascertain whether it is actually there or not. We can do that by two common methods. First, get a CT scan done of the head. We can look for the signs of increased pressure, or we can take an ophthalmoscope and look at the in ophthalmoscope we look at the macula, because the retina is directly connected with the brain. So if there is increased pressure, there will be bulging of the macula. If these are seen, lumbar puncture can be delayed or can be done very cautiously. Another important thing that you should remember, if the patient has any history of bleeding disorder. If there is a bleeding disorder present, what might happen is that after the procedure is done, there will be increased bleeding within the cerebrospinal space itself, further increasing the intracerebral pressure. So these are the two main important. These are not contraindications. Please remember, these are not contraindications, but you should keep these in mind. Okay. Next important step is whether you perform a lumbar puncture or not. Most important part is, if you see a patient suspected of having meningitis, first is you have to admit the patient, preferably in a position where the patient can be monitored very closely. That is intensive care unit. Next is you have to administer two important things, that is the antimicrobial agents and corticosteroids. Why corticosteroids? Because it reduces inflammation. Not only the signs and symptoms will be resolved, but also the pressure that is increasing will also go down. These are the two very important parts. Now, generally it is said that you must give the antimicrobial agents after taking the cerebrospinal fluid. That will lead to better yield of the organism and better identification, hence better diagnosis and management. However, this is not an indication for withholding antibiotics. Try to understand what I'm trying to say. This is a medical emergency. If you feel that you are not being able to perform the lumbar puncture, or by any reason the lumbar puncture is being delayed, do not withhold antimicrobial agents. The more you delay, there is a high chance that you may lose the patient. Okay. Now let us take the scenario that you have taken the cerebrospinal fluid. Now what will we actually look for in the cerebrospinal fluid? We are looking at the change in the parameters. If we are looking at the change in the parameters, we need to know the normal parameters. So normal parameters would include, so these are the normal parameters. Normally CSF will have very few cells. Among the white blood cells will have mainly lymphocytes and very few in number, that is 0 to 5 cells. This is the normal picture. Then CSF has two more important parts, that is the protein and glucose. Now CSF protein and glucose will also be, normal region is less than 40 milligram per deciliter is the protein, and CSF glucose will be about 50% of the simultaneous blood glucose. That means whatever the blood glucose level is there, about half will be present in the CSF. Now let us look how this parameter changes if it is a bacterial cause of meningitis. The first, what will happen? Because the bacteria is present in the CSF, what it will do? It will cause inflammation. And whenever there is inflammation, what will happen? The capillaries will leak and white blood cells will come into CSF. What is the most common type of white blood cell we will see? Neutrophils. Now look at this picture. In bacterial meningitis, we have leukocytes, predominantly polymorpho-neutrophils. Okay. Then, because there is huge number of both bacteria and neutrophils, what will happen to the overall protein? It will increase. So protein will be grossly elevated. Now look at the CSF glucose. If the bacteria is replicating, it needs some nutrition, it will take up the glucose in the CSF. So the glucose of the CSF will be low as compared to simultaneous blood glucose. This is very important. So that means whenever you are taking a CSF sample, you should also send a blood sample for estimation of the blood glucose. Why? Because blood glucose will vary according to the time of the day. There is a variation whether the patient is taking the meal or not. There are many factors. Understood? So this would be the first change. Now, if the picture is like this, that the cells have increased but neutrophils are not the predominant, it's still lymphocytes. The protein is elevated and glucose is almost normal. What would this reflect? This inflammation is there, however, it's not acute inflammation. If virus is causing inflammation, then the lymphocytes will be recruited and viruses will not take up the glucose. So this is the picture of viral meningitis. Now this is very important in case of acute meningitis. Now, also we have to ascertain two important cause also, like the chronic meningitis. I have told in chronic meningitis we have very importantly a tuberculous meningitis. In tuberculous meningitis we have what is called as mixed pleocytosis. Although lymphocytes are increased in number, we can find a significant number of neutrophils also. If that is the picture seen, along with increased protein but glucose is reduced and the presentation is slightly insidious, we may consider it to be as tuberculosis. Sometimes we can also find, after taking the CSF in the test tube, we may find a coagulum, also called as a cobweb coagulum. This may or may not be present. These are the features of tuberculous meningitis. In case of fungal meningitis, fungus will also reflect by increased number of lymphocytes, increased protein and decrease in glucose. This picture will indicate you whether it is a bacterial meningitis or a viral meningitis or a tuberculous meningitis or a fungal meningitis. This is the first step. Now, what are the other investigations that you must send? This is one aspect. It is a CSF study. In CSF, what we are looking at? TC and DC. That is total cell count and differential cell count in the CSF. Then we are looking at CSF protein, CSF glucose, Next, what test we have to do to confirm the bacteria? Good. First, then we need to look at the microscopic examination. So, microscopic examination, we need to do gram stain for bacteria. Obviously, viruses, we need an electron microscopy that is generally not present. So, next would be for tuberculosis, any particular kind of stain. AFB stain, acid fast stain, and for fungus, any kind of particular staining. Right, not cavities. It's the India ink or negative stain. So by microscopy, we need to send this. After microscopy, what more can we do? We can go for antigen detection. What kind of antigen detection we can do? See, not all bacterial antigens may be present, but some of the bacterial antigens may be present, like Haemophilus influenzae, Neisseria. These bacterial antigens may be present. Then we can look for fungal antigens like cryptococcal antigen. Anything else? Before that, we can also look for antibodies. Some of the viral infections may also produce antibodies. Okay, like measles, mumps, these antibodies may be present. And even antigens like herpes can also be present. Next, what we can do is, she has already said, we can go for culture and sensitivity. Most of the bacterial pathogens can be identified by culture and sensitivity. Okay, I am not going into the details of the culture and sensitivity. Commonly, 3 culture media is used. One is obviously blood agar, McConkey agar, and very importantly, there is chocolate agar. Why chocolate agar? Because some of the fastidious bacteria cause meningitis, namely Neisseria, Haemophilus. They will not be isolated in the routine blood. Okay. Cryptococcus is easily isolated from blood agar. We can also put a HDA culture for cryptococcus. As far as tuberculosis is concerned, we can go for culture for tuberculosis both on solid agar or liquid agar. So it may be solid or liquid based on whatever that is available. Advantage of liquid culture would be that the turnaround time will be about 1 week. For solid culture, it will be about 8 weeks. Okay, so this is culture. Any other test that we can do on CSF? Molecular methods. Okay. Now, what type of molecular methods? Now, first is, we call it as, in your examination, please don't write PCR. Okay. Always write nucleic acid amplification test. PCR is one of the steps of nucleic acid amplification test. So, among the nucleic acid amplification test, commonly what is done is, we can do for tuberculosis, is also called as CBNAT. So that these are available for many bacterial, fungal, and tuberculosis, like GeneXpert or TrueNat. Another type of molecular test is called as, very commonly used nowadays in specialized hospitals. It is also called as film array. It is called as film array. What is this? This is also a nucleic acid test, but in which we can run for multiple pathogens in a single test. For example, when we run the meningitic panel, we test for some bacteria which causes meningitis, the viruses which causes meningitis, and also the fungus causes meningitis. So in one test, all the results will come up. This is called as film array. Have you understood or not? Okay. See, film array is very simple. For nucleic acid amplification test, we need to test for each and every pathogen separately. One test for TB, one test for fungus, one test for, say, strep pneumoniae, for H influenza. But in film array, we can run all these tests simultaneously. So the turnaround time is and yield is also higher. So these are the all methods by which we can detect the pathogen in the CSF. Furthermore, we can use many other tests also. For example, simultaneously we need to do some investigation in blood. What would be that? No, blood culture. This is very important. Why? Remember, I have told you the most common route of transmission is hematogenous. So, whenever you are dealing with the case with acute meningitis, there is a high probability that the pathogen is also present in the blood. So, also send blood for culture. And some of the bacterial antigen may be found in the urine also. So, we can also detect from the urinary antigen. So, these are the tests that we can do for diagnosis of acute diagnosis of meningitis. Understood? Now, if a question comes, can you write for the laboratory diagnosis? So, first we need to look at the presentation, whether it's acute or chronic. Then we have to look at the clinical signs, any ancillary history. Why this history is important? I'll just go through very briefly. Okay, why this is important? First factor is age. Based on the age, the pathogen also changes. Look over here. In neonates and young infants, where do these infants get the infection from? From the environment. So, what is the environment of a baby, infant? Is the mother. So, now look at this. The most common organism causing is Streptococcus agalacti. Where does this organism reside commonly? In the female genital tract. That is the reason why postpartum, if there is signs of meningism or sepsis rather, this is a very importantly causing organism. Another is Listeria monocytogenes. Is present in the water. And other enteric bacilli. These enteric bacilli are commonly found in the labor room, the gynae OTs, and also not in the OTs, in the labor room and in the neonatal units. They cause hospital acquired infections. Now, if I ask you, what are the common organisms causing infection in the infants, causing meningitis? Can you name them? Then it will be very easy. You can say, obviously, Streptococcus agalacti, Listeria, and enteric bacilli like E. coli, Klebsiella, etc. Now, let us look at older infants and children. Where does these children go to? They go to play school and school. So, it will acquire the infection from the community. So, there must be some specific organism. What are the specific organisms over here? The capsulated bacteria. Streptococcus pneumoniae, Haemophilus influenzae B, and Neisseria meningitis. Understood? Now, for middle aged, that is the adults, there must be a predisposing condition. Like there must be any chronic infection, either sinusitis, mastocytitis, or a trauma, or an infection elsewhere in the body, or it can be caused by the same capsulated organism that occurs in the childhood. Now, only remember one thing. Staphylococcus aureus, where it is commonly present? Staph aureus is present all over the body. It is present on the skin, the anterior layers, the armpits, all over the body. Now, this is both a commensal of the human being and is also a pathogenic organism. And it can cause meningitis in all age group, in any kind of patient, whether immune susceptible or not, aged or not, infant or not, it can cause meningitis in all population. That is one organism. Okay. Some of the specific immune deficiencies may be caused by some of the bacteria, like if it is a cell-mediated immune defect in the cell-mediated immunity, obviously the infection will be more predominantly caused by organisms which are intracellular, like listeria or tuberculosis, if there is defect in human immunity or splenectomy. Have you read about infections after splenectomy? No. What is this? Anyone? Acha, what is the role of spleen in our body? Action. Huh? Now, what does the spleen do? Okay. So, basically, it filters the blood in a broad term, right? So, along with the filtration, what it also does, some of the organism which does gains access into the bloodstream, it also removes it. Now, if a patient has undergone splenectomy, what will happen? These organisms will proliferate. Now, specifically, capsulated organisms are removed from the body predominantly by the spleen. These capsules have antigens. These antigens are detected and are removed, including cells of the body which have these organisms. If the spleen is removed, what will happen? These capsulated organisms will not be removed and will cause severe infections. These set of infections are called as overwhelming post-splenectomy infections, OPSI. Okay. So similarly, if a patient has undergone splenectomy, the capsulated organism can cause meningitis in this particular set of patients. Okay. So in very short, this is CSF analysis, then blood counts and blood differentials, metabolic panels, and also the nucleic acid amplification test. This is the most important part. First is you have to administer antimicrobial agent. What type of antimicrobial agents? What type of antimicrobial agents? Read the slide. What are the points? First, the last and the most important is admit the patient in ICU for repeated monitoring. Second would be to give antimicrobial agents and give corticosteroids. Third, very important, monitor for the increased intracranial pressure. And there are many steps to reduce the intracranial pressure. You can have to take those as and when required. So the commonly given antibiotic is a third generation cephalosporin along with the vancomycin. Why vancomycin? Because I have already told you Staphylococcus aureus can cause meningitis, and there is a particular strain of Staphylococcus called as methicillin resistant Staphylococcus aureus, which is resistant to all beta lactams. For that, we need to give vancomycin. After the diagnosis has been made, we can de-escalate, that is, we can stop giving vancomycin. Additionally, we may have to give anti-seizure drugs because meningitis means inflammation. The inflammation may also be seen in the cerebral cortex. Any irregular neural irritation in the cerebral cortex will lead to seizures. Now, how to prevent? Now, if the question comes, how will you prevent meningitis? You have to look at the specific age group, right? Now, what is the most important predisposing factor in case of infants and neonates? The infection comes from mother. So, peripartal screening of the mother. That is, if strep egalacti is seen in the genital tract of the mother, we can give the antibiotics so as to prevent this infection, right? Second, proper infection control process, if it is present, it can reduce hospital acquired infections. Secondly, now comes infections in the childhood and adulthood, commonly caused by the capsulated organisms. For that, we can give vaccines, right? Because children will go to school, adults will obviously interact with other people, we cannot isolate them. For that, we have vaccines. The first vaccine would be for conjugated pneumococcal vaccine for streptococcus pneumoniae. There is a vaccine for Haemophilus influenzae B, and obviously quadrivalent meningococcal, that is for Neisseria meningitis. So these are all vaccine preventable. Next, for adults, what is the predisposing condition over there? Is immune suppression. Elderly adults, so we have to reverse the immune suppression. And if there is any specific cause, like say a sinusitis or a mastoiditis or a trauma, we need to give proper antimicrobial therapy for that. So these are how we can prevent the infection. Now let us study some of the cases. First is an 18-year-old patient presented with headache and skin rash. The patient reported a history of sore throat in the past 1 week. 1 day prior to admission, he experienced nausea and vomiting and some spots on legs, arms, and abdomen. He was admitted and then he presented with fatigue, headache, neck pain, and photophobia. On examination, the respiratory rate was increased, temperature was increased, and there were signs of meningism, including Kernicks and Buzin's. The examination shows rashes like this. CSF shows gram-negative cocci along with other CSF. So this is a kind of presentation presented with Neisseria meningitis. Another case, a male baby was born full term with spontaneous vaginal delivery. The mother was primary gravid, no complications over there. The child was discharged and then the child came back with fever, decreased feeding and fuzziness and lethargy. So this is a common kind of presentation in infants. The infants will very seldomly, obviously they can't speak, they will not say we are having headache. The signs that is seen is increased irritability, reduced feeding. So the child was given empirical antimicrobial agents, blood counts was done. Then on culture, we have recovered gram-positive bacilli. This would indicate Listeria monocytosis. Now, just 3 cases as an example. Now, a 57-year-old female with a past medical history of Hodgkin's lymphoma and on steroids and immunosuppressive drug, again presenting with signs of meningism, and now in CSF we can see purple color cocci or gram-positive bacilli in pairs, also called as diplococci. So this is an infection caused by Streptococcus pneumoniae. So that would be for acute meningitis. Wait, that was about bacterial meningitis. Now we are talking about aseptic meningitis. Aseptic means, I have already told you, it does not mean that no organism is present. It used to mean like that. Now aseptic meningitis predominantly means viral meningitis. Now typically what is seen in viral meningitis, there will be pleocytosis, predominantly lymphocytic pleocytosis. The protein will increase but sugar levels will not be reduced. So this is the common presentation. Now among the common viruses which cause meningitis would include, number 1, the enteroviruses. Among them the Coxsackie and ecovirus. Eco stands for enterocytopathic human orphan virus. And more commonly we have herpes simplex and varicella zoster and West Nile virus. These are the common. Some of the uncommon diseases would include adeno, influenza, mumps, measles and NCM viruses. Many a times Some of the bacterial causes, like I have already said, the chronic meningitis may also present in the initial part with signs and symptoms of aseptic meningitis. Among them would include like treponema or borrelia, fungal infections and parasitic infections. Other important differential diagnoses would include systemic diseases causing meningeal inflammation like autoimmune diseases or drug induced, and sometimes the cause may not be seen, in which case we call it as idiopathic. Okay. In the respiratory tract, you have read about carb 65. পড়েছো তো? carb 65 পড়ো না? রেসপিরেটরি ইনফেকশন পড়ানো হয়েছে তো? নিউমোনিয়া, এবার বলো না নিউমোনিয়া পড়ানো হয়নি। নিউমোনিয়াতে carb 65 কি? সেপসিসে একটা স্কোর পড়ানো হয়েছে কি? সোফা, SOFA, sepsis score, like for diagnosis of sepsis there is a score called SOFA score or the carb 65. In case of pneumonia we have a score called bacterial meningitis score by which we can diagnose in case of meningitis. So obviously the score is very simple. If we have a positive gram stain, 2 points, cerebrospinal fluid more than 80, 1 point, peripheral blood neutrophil. This is peripheral blood neutrophil. That means it is called as bacterial infections will cause increase in neutrophil in the blood. We have 1 point, history of seizure and absolute neutrophil count in CSF. If these are present, we can say that it is a case of bacterial meningitis. So this is the score that we can see. Okay. Now a very important part of diagnosis of chronic meningitis is a radiological investigation, especially CT. Like the herpes virus, it will commonly affect the temporal region. So they have some predilection, not absolute but some predilection. So these can be seen. There are many causes. এগুলো এখন পড়ার দরকার নেই তোমাদের। এটা দেখা যাচ্ছে? So among the fungal causes, Cryptococcus is important. We have a mononuclear cells, then India-ing positive. The CNS features will also depend on some of the specific organisms. I know this is not required for you people. What I'm trying to make you understand is, in case of chronic meningitis, localized predilection is also important. You don't need to remember now. Some organisms will have some specific predilection to particular areas. For that, we can delineate them with a radiological investigation. Then we have the CT scan, the MRI with either a T1 or T2 flare. Those can be used. So now after that we have encephalitis. Now what are the common, now you people will tell me what are the common organism causing encephalitis. JE virus, very good. Anything else? Toxoplasm is a parasite. Then cerebral malaria, right? So whenever you come across a question of central nervous system infection, you have to keep in mind this. For as far your examination purposes, you have to consider acute meningitis, chronic meningitis and encephalopathies. Among the encephalopathies, we have direct viruses which causing encephalitis and parasites causing encephalitis, or Other parasites like neurocysticercosis, causing space-occupying lesions, or systemic infections like malaria, which may have cerebral manifestation like cerebral malaria. Okay. Sometimes in your exam, a case of cerebral malaria can also be given. Read and understand the question very, very carefully, whether it is actually of meningitis or not. Look for the signs of meningism. If the question is for meningitis, there will be an indication that signs of meningism is there. Okay, for your exam purpose, not for your practical purpose. Practical world is very different, vastly different from your examination point of view. Okay. If the question is indicative of encephalopathy, the predominant indication will be given by the delirious or the comatose state of the patient. Okay. So don't get confused in between for your examination purpose. So that was all about the infections of the central nervous system. Just a recapitulation of everything. The predominant syndromes will be meningitis syndrome, meningitis, encephalopathy, space-occupying lesions, and other infections like shunt infections and myelitis or toxins. So these are the common. Among meningitis, we have either acute meningitis or chronic meningitis. Acute meningitis can be bacterial or viral meningitis, can also be fungal. We can also classify the meningitis based on the etiology, bacterial meningitis or fungal, tuberculous, viral or parasitic meningitis. Again, meningitis can be classified based on the age of the patient who is affected. Whether the age affected is from 0 to 1 year, or a preschool or childhood, adulthood, or in elderly. And for diagnosis, the approach would be CSF. First, we have to look for the signs and symptoms. Predominant signs and symptoms would be fever, headache, vomiting, nausea, vomiting, and that is signs. That is, you have to observe. The patient will not tell that there is cardiac sign positive. No. Okay. On examination, the patient may be delirious, comatose, increased. If there is fever, there will be increased heart rate, increased reduced blood pressure, and neural manifestations like cardiac surbusiness can be present. Next important state would be to resuscitate the patient first and to administer antimicrobial agents. The antimicrobial agent would be antibacterials, antivirals, antifungals. Antiviral in the common nature we use acyclovir because herpes simplex is the most common. Then we need to look for signs of increased intracerebral pressure. If it is not there, then we can go for lumbar puncture and examine the cerebrospinal fluid. The tests that can be performed on cerebrospinal fluid include: number one, what are the tests we need to do for cerebrospinal fluid? First is cell count, total cell and differentials, right? Second would be protein. Third would be glucose. Next, microscopy. In microscopy, we have to do gram stain, acid fast stain, and indairing for fungal. Next, what we can do, we can go for antigen detection or antibody detection. Next, we can go for culture. Commonly, culture is done on media, blood, chocolate. Next, we can, among culture, there is also fungal culture. We can go for HDA, and tuberculous culture is a solid or liquid. Next important would be go for nucleic acid amplification test, either singly or in a array, also called as film array. It is not a big difference. It is multiple tests done in a single file. Most of the viruses can be identified by the molecular test. Along with that, we have to send for blood culture, and some of the organisms can be identified by urinary antigen test. Okay. After these are the investigations. After that, what we need to do is we need to de-escalate. Suppose the organism is identified, if it is a bacterial, obviously we need to stop the antivirals and the antifungals. And among the bacterials, based on the susceptibility, we need to change. Okay. Important management step would be to admit the patient in not always ICU, but in proper care where proper care can be given. We have to monitor for increasing intercerebral pressure and also symptomatic management like anti-seizure medication if seizure is